Well, welcome everybody. Bienvenidos. Buenos días. Thank you so much for joining us today for our SWOG Latin America Initiative Symposium. We actually are super happy to have this huge room with a beautiful view, little open. So thank you everybody for being here. Today, what we have prepared for you, it's a symposium that really touches on tobacco and tobacco-related cancers. We acknowledge that this is a big healthcare problem, not only here in the United States, but in the rest of the world. And we want to learn what is happening in Latin America, what our partner sites are doing. And we have divided our seminar in our symposium in a couple of parts. So the first part, we're going to have a number of lectures, 4 lectures, really touching on tobacco control in Latin America, smoking cessation, and treatment of lung cancer in Hispanic populations. And then we're going to go to the second part where we're going to talk about the lung committee opportunities within SWOG. And for that, we are honored to have here Dr. Ann Chiang, who is the executive officer for the Lung and Thoracic Committee, to then move into our last part where we're going to talk more specifically on the activities in each one of our partner sites. So we do have a hybrid meeting. We have a number of our colleagues that are online. Some of them are going to be presenting from there. So welcome also everybody that is joining us online. And of course, want to welcome, and I don't know that she needs any presentations, but Daisha Kristen, who has been, pivotal putting this meeting and agenda together. So without further ado, we're gonna start with the first part on our talks on tobacco and tobacco-related cancers. And remotely, our first speaker is Dr. Barjona. He joined us from Guatemala. He's the director of research at the Integra Cancer Institute. He's also the director of research and education at the cardiovascular unit in the hospital where he works in Guatemala. He has been incredibly involved in tobacco control. He serves as editor of the British Medical Association. He's a panel member of the Cochrane Collaboration for Public Health and Nutrition, sharing his expertise in tobacco control. And he's going to talk to us about tobacco control in Latin America, new products, new challenges. Dr. Barjona, bienvenido. Thank you so much for joining us.
Thank you all for your time and inviting me to the SWOG meeting. I'm going to briefly touch upon this tobacco control in Latin America in the 12 minutes, in the next 12 minutes. If you can pass to the next slide, please. So I have no conflict of interest to declare. Oops, that's going a little bit too fast. Could you back up one, please? Thank you. Brief summary of what I'm going to do. Briefly touch upon the scenario of tobacco control in the region, what's going on in Guatemala that is not that different from what's happening to the rest of the Latin American countries, and finally close with some conclusions, hoping to leave some time for Q&A. Next, please.
Are you doing it or am I doing it? This doesn't work, so you have to do it.
So the WHO, and this should be not new to all of you guys, about in 2003 implemented the Framework Convention on Tobacco Control, which is the first public health treaty ever established in order to control the tobacco epidemic. And they have this monitoring tool called the Empower, which stands for Monitor, Protect from Secondhand Smoke, Offer Cessation, Implement Warning Labels, ban exposure to advertising and point of sale and so on and so forth, and ultimately raise taxes. So this is kind of a scorecard which countries should abide to. Next, please. So in general, you can see there has been progress in Latin America. Most of the countries have ratified the SCTC. You can only see Argentina, Cuba, and Jamaica and the Dominican Republic have not ratified the FCTC. And at least all of these countries have implemented at least one of the articles of the FCTC of the Empower scorecard. Brazil probably is the one that has made the most progress of all the countries. Next, please. And if you see at the big picture from the next, please. From 2005 to 2020, to the 20, oops, that's too fast. One more, please. Thank you. From 2005 to 2021, there has been progress in the region. So you see the light green, and then later on you see the dark green. There's more countries with the dark green, which is good news for the region. Next, please. Yet, unfortunately, that's not the entire story. And the FCTC was drafted in 2003, 2001. We didn't count it. We didn't know that the industry was going to come up with new products. And this is from one of the tobacco industry documents. And you see that second sentence says the segment gives the capacity not only to retain consumers, even in some cases to attract new consumers, but to address wider consumer trends such as desire for customizability. They were referring to capsule cigarettes. Next, please. This is the usual cigarette as we know it. This is not new. This is a pretty well studied, and we know a lot about what's in the product and the consequences of consumption of cigarettes. Next, please. Yet this is not the whole story. And the industry, as you can see from the tobacco industry documents, started working on capsule cigarettes. And this is a capsule cigarette as you would find in Latin America. In the filter, they can have either not only one capsule, but more than one capsules and from different sizes. And once the smoker crushes the capsule, it has a liquid inside that it will vaporize and change the flavor of the smoke. And there's a lot of ways you can tailor it to different flavors, mango, strawberry, and some mango, bacon, and so on. And so it's not only about how many capsules, but also how many flavors. Next, please. Now, unfortunately for the region, the top 3 consumers in the world of capsule cigarettes are in Latin America. And you can see up there, Chile, Peru, and Guatemala. Up to a third of the cigarette market in these countries belongs to capsule cigarettes. Those are not included in the FCTC. And that's one of the regulatory questions that I'm going to be talking for the rest of my talk. Next, please. And this is the new cigarettes, the new products, the capsule cigarettes have come to alter how advertising is happening. And this is a power wall, a point of sale advertising as you would see it right now in Guatemala. You can see the usual Marlboro, the Marlboro red, all down there to your left, to your down right. Those are the Marlboros, but most of the point of sale advertising is for capsule cigarettes. This is a Lucky Strike that has 4 different capsules in the same cigarette pack. Next, please. But it is, excuse me, but it is not only about the cigarette stick and the filter. The pack has also evolved a lot since the FCTC was implemented. And this is not taking into account that Guatemala and most of the countries in Latin America have not implemented graphic warning labels as mandated by the FCTC. You can see it's a much more appealing pack with a lot of colors and very modern. You can see that the capsules, the fact that they have capsules has made them able to make it a more colorful cigarette pack. Next, please. As I said previously, this has also altered how advertising is happening, and this is a point of sale in a gas station in Guatemala. The arrows, each one of them is pointing at one marketing strategy, and you can see there are at least 8 advertising strategies at the point of sale, but not only at the amount of advertising, but the product that's being advertised. As I talked briefly about the point of, the capsule cigarettes, which is most of the advertising that you would see for cigarettes, but also electronic cigarettes and heated tobacco products, which I'm going to talk shortly about. Next, please. So I briefly talked about the cigarettes itself. Now we have the new, well, not so new products. Electronic cigarettes have been around for more than 10 years now, and it's a more complicated product than the conventional cigarette is. It has a battery, it has a liquid, it has a coil, and all of those could be customizable and change over time as the battery loses its power, but also as the liquid can be modified. So it's a much more complicated product and harder to understand. Next, please. And the variety, as I just said, is customizable. This is a slide we took during the pandemic. You can see the amount of different liquids, but also different type of electronic cigarettes. You can have pods or mods, which is a different type of delivery system. and the liquids you can put in them are also very different. Also, I'm not going to go into detail in the interest of time, but the prices there's a wide range going from $1 or so to a cup for $20. So thus far, it's not a very cheap product, but as the product becomes more and more available, prices are likely to go down. Next, please. How do we regulate e-cigarettes? Well, most of the countries do not do anything at all. And even those that have done it, it has not worked. And if you see in Central America, right there below Mexico, Mexico has banned them. Yet you go to Mexico and you find them everywhere. You see there, Guatemala is in gray. We have absolutely no regulations. And there's only few countries in the world that have banned them. And the effectiveness of banning them is not that clear how it works, because it's a product that can be easily imported. The United States has a story about Juul. I recommend a Netflix documentary on Juul that just came out. Highly recommend it. Next, please. Now, if we didn't have enough trouble really with the conventional cigarettes and the electronic cigarettes, about 10 years ago, Philip Morris introduced the heated tobacco products. IQOS, we don't know exactly what it means. The tobacco industry claims it's just an acronym. We thought it could stand for I Quit Ordinary Smoking, which is a new product by Philip Morris that heats as opposed to burning tobacco. Then there's some research right now that actually is that heating is actually burning because the temperature actually goes up. Next, please. This is just a normal IQOS. That's how it looks. It is a cigarette stick. As you can see in your far left, you can see the normal Marlboro cigarette stick, and then you could see the heat, HEETS. That's what you would recharge into the IQOS. There's starting to emerge data about the endothelial damage that an IQOS causes, and it's very similar to what a conventional cigarette does. Likewise, there's data on tobacco-specific nitrosamines, benzaldehydes, particularly that we know are group 1 carcinogens, according to IARC, that the levels that are released by the smoke from an IQOS could be even higher as the ones released by a conventional cigarette. Next, please. Where's IQOS marketed? It's penetrating the market pretty quickly. Guatemala was the second country to be selling IQOS. It's followed by Colombia, and now we have a new one in Guatemala called LIL, L-I-I-L, which is some cheaper type of IQOS, but produced by a South Korean company, and Philip Morris is marketing here. In the US, the FDA banned importation of the IQOS, yet it's going to be manufactured in the US, and therefore it's going to show up in the market in the US, I would say, in the next year or so. Next, please. How is it marketed? It's a very high-tech product. It's targeting a young adult market. And you can see this is at the point of sale, very much the same strategy they use the conventional cigarette, close to confectionery, candies, and products that are appealing to adolescents and kids. However, the data we have thus far is that consumption is mostly among young adults trying to switch to a safer product as opposed to the conventional cigarette. Next, please. Now, what's happening with consumption among adolescents? And unfortunately, Guatemala, as most Latin American countries, lacks population-based data. Mexico has good population-based data, just as Brazil does. But it's interesting what happened during the pandemic. And when you see here in the left, in wave 1, which is this is a sample of about 3,000 adolescents we surveyed in Guatemala. In 2019, the pandemic hit, and when we did 2 further waves during the pandemic and after the pandemic. Consumption of electronic cigarettes has surpassed by far consumption of conventional cigarettes, from a 30% compared to an 8% of conventional cigarettes. However, and there's still debate of what happened with the pandemic, because we also not only were isolated from the social contact, but also we had to go to a face-to-face interview, do online interviews. So take this data with a grain of salt. But you see the second wave, consumption of electronic cigarettes dropped from 30% to about 3%. And those using, from 27% to about 14%. My slides here are not showing that well. From about 27% to 14%. What was the effect on the pandemic on consumption? We don't know yet. And what is the effect now that we post-pandemic on consumption of these products? That's still yet to be seen. Next, please. And just to conclude, so there has been some progress in the region, particularly in Brazil, Argentina, Mexico has made some progress, but the progress has not been even to all countries. And enforcement is still an issue with some of these policies. We have new products with all marketing strategies, but also we have new consumers, not only about adolescents, but also amongst adults who are switching to the heated tobacco products. I think we have huge regulatory challenges ahead. For the most part, these are weak political systems. There's still the issue about harm reduction, which we can talk about during the Q&A, about using less harmful products compared to the conventional cigarettes. We can argue if they're really less harmful and if they're going to be actually used for harm reduction for cessation. Does banning works? I think it could. How do we implement it? I think that's still a challenge. Again, I insist, considering the Latin American political scenario. Flavors are definitely one of the key drivers of this pandemic. You saw all the products, the new products that I mentioned, they all have different flavors. And I think that's a huge challenge for all of us. And I'm going to stop right there. I think I ran out of time. I apologize. Thank you very much. Thank you again for the invitation. I'll be happy to take any questions.
Dr. Barnoya, that was really interesting. We're going to have time probably for 2 questions. If somebody has any questions in the audience, I will just ask them to walk to the mic so the our colleagues online can really hear us. I will probably just start by asking, this was very enlightening for me. I really had no idea about all this amounts of products, but I think sometimes in the community, there's this notion that these new products are really not harmful. And since they are newer, I guess we just don't have a lot of data on the long-term effects that they can have. Like any ideas, in terms of, do we think that the risk of head and neck cancers or lung cancers or even others, any thoughts that you can have on this?
That's a challenging. I'm not sure I have a right answer to that, but I'll give it a try. First of all, yes, there's a perception of healthier, and we have data from among adolescents, and the fact that they're using colors and flavors and fruit flavors for the products definitely increases the perception of not harmful or healthier or less harmful. That's on the one hand. On the second question about the long-term effects, it's really hard to evaluate because as opposed to the cigarette, these are different products and different types of consumption. Adolescents and adults puffs, they give a puff, and some of the products have like 1,000 puffs. Some of them have only 100 puffs, but also the voltage, the battery. It also depends on how high the temperature is, how high the liquid is being vaporized, the amount of constituents that will be released. There is data, there's starting to come out data about type 1 carcinogens being released in the vapor that is being inhaled, but also exhaled, the secondhand smoke vapor, if I might call it, that has been saldehyde. So now from that to cancer risk, and I think that's where we're going to have to draw the line. Do we wait for the data to start accumulating, or do we go by the precautionary principle and start banning them on the basis that we know that they have some of the carcinogens that we know are harmful to one's health and cause cancer?
That was a very good way of answering the question. And I see Dr. Crowley walking to the mic. He's going to have a question for you.
Joaquin, great to hear from you again, my old friend. I wonder if you could comment briefly on the possible future involvement of Guatemala in the SWOG Latin America initiative.
Great to hear from you, John. Absolutely. I had a talk with Eddie, Dr. Garzusi. Eddie, you know him very well. And absolutely, we would love to get involved with SWOG again. Integra is running clinical trials. This is just one thing, but we're also conducting the studies on adolescent use of electronic cigarettes and heated tobacco products. But so absolutely, I have no doubt that we would be very much interested in getting involved with SWOG.
Oh, that is wonderful. And what we will do is now move to our next talk. Our next speaker is a longtime supporter of the Latin America Initiative, Dr. Irene Tamimauri. She's an assistant professor in the Department of Epidemiology, Human Genetics, and Environmental Sciences at the School of Public Health at the University of Texas Health Science Center in Houston. She's member of our DI Leadership Committee here in SWOG, among others. And she has done a lot of work from the empowering of patients perspective. So she's going to talk to us today about empowering cancer patients and providers through the use of digital tools for smoking cessation. And smoking cessation is one of her areas of expertise. Thank you so much for joining us again. We love to have you always. Thank you.
Thank you so much. It's always a pleasure to be here. I am a huge believer on this Latin American initiative, and I'm just hoping that we can continue pushing through to make more relevant our presence in the SWOG overall efforts. Just answering and kind of giving a little bit of more information about your question. Complementing what Dr. Barnoya said, the development of an adolescent's brain is stopped at 25 years old. The amount of nicotine that the electronic cigarette adolescent users are consuming is humongous. And that is impacting already and is already published. So, and the other major thing in terms of cancer prevention is that there has been studies showing that electronic cigarette users or the electronic cigarette is becoming a bridge to become dual users. So these individuals start using the electronic cigarette in the places where they cannot smoke, and then they become cigarette smokers. And in a region like ours in Latin America, where buying electronic cigarettes is costly, traditional cigarettes still are the main consumed product. So, and this is the main focus of my presentation, smoking cessation. What we have done over the past years in Latin America is to assess what is the problem in our region in terms of consumption. But with the help of the Impact Award through the Health Foundation, my team tried to move a little bit forward on, okay, what we do now. And what we have done is to develop digital tools to help smokers to quit. And this is the focus of my presentation. So the background of that effort was the STOP program, where we trained cancer care providers into smoking cessation and making them aware that oncology settings can be ideal places for implementing smoking cessation interventions. And we train 2 cohorts, one in Colombia and one in Peru, 29, well, we reach out to 30, that was the cap. And in Colombia, we retained 29, and in Peru, we retained 24, which is a huge retention rate considering that the program lasted 6 months. And we had a 3rd cohort plan in Brazil, but unfortunately, COVID hit. And what we did in this program is not only provide the knowledge necessary to these cancer providers in terms of smoking cessation and smoking overall, and how the cancer diagnosis can be used as teachable moment for initiating an intervention in smoking cessation, but we also changed the attitude. Our previous work in Latin America showed that the tobacco use has been normalized to the level that even at cancer centers is you can find cancer care providers using tobacco products. So let alone imagine these providers won't be more motivated compared to non-smokers to assist their patients to quit smoking. So what we wanted in this program,
If you have to point it the other direction.
all right, what we wanted to show to these cancer care providers is that a brief counseling on smoking cessation can be done in 3 minutes, approximately. And that is a humongous step towards assisting a patient into their quitting efforts. So sometimes, and I'm speaking from personal experience as clinicians, we think, oh, I don't have time of that. I'm not a psychologist. This is not my, but it takes only 3 minutes. Maybe not to implement the intervention yourself, but to redirect that person to a smoking cessation unit or to the quit line and assist that individual, because it has been proven that cancer treatment is negatively impacted if the patients continue smoking. Oh. All right. So, I don't know where.
It's more like you push
Do,
it,
do we
like-
have the arrows and?
Do you have another pointer that might work better?
Okay, can you go back to one slide, please? 2, actually. Yeah. No, you're going forward, backward.
2 backwards.
2 more. Okay. And as I mentioned to you, COVID happened. So what we did in that time, besides publishing our efforts, it was reviewing the evaluation that we implemented in that training program. And what we found, and can you please move one, please? What we found is that the trainees were trying to do the intervention smoking cessation, but needed to go back to their notes or the PowerPoint presentations that we provided to check out about the dosage of the nicotine patch or what to say if the patient was reluctant to quit smoking. And it's where our team said, okay, we need to come up with a digital tool that can assess these individuals. One more, please. So they don't need to disrupt the opportunity and act on that. And it's how Decision T, the app that we developed, came in place. And we were gracious enough to have the support of the Hub Foundation to use the remaining fundings that we had for Brazil to focus on the development of this smartphone application. Next, please. Decision T is based on really well-known models for smoking cessation. Then we have first the 5 A's, which is you should always ask to your patient if they are using any type of tobacco product. You should advise, well, you have a diagnosis of cancer, chemotherapy won't work as well if you continue smoking. You should assess, are you ready to quit smoking? And you should assist. Well, we have a unit, a smoking cessation unit in our cancer center, or I can refer you to this other facility where you can have assistance in your quitting effort. And you should arrange follow-ups, constant follow-ups. So as you can imagine, a cancer diagnosis is an ideal opportunity to implement smoking cessation interventions because you see these individuals repeatedly. And then we have also, or base our app in the transtheoretical model. For those who don't know, not all the patients are ready to quit smoking, and it's important to assess that individual. I was trained in Venezuela, and the approach that we have for smoking is so punitive as a clinician. You are like, oh, I'm going to have a surgery with you while you quit, while you continue smoking. Like if it's a on and off switch that the patient can do. Just so you know, nicotine addiction is way harder to quit than heroin addiction. It's really hard. So the patient continues smoking, not because they are like, oh, I'm enjoying this life. It's because now they are hooked and they cannot quit. Next, please. So we did the due literature review. We checked what are the existing algorithms published and are evidence-based. We designed the app and we developed it. And that took pretty much most of the pandemic in that effort. Next. And we tested just last year and concluded that testing. Next, please. So because we were in the middle of the pandemic and cancer centers were just dealing with COVID, and I had really strong connections with the HIV clinicians, I decided to start the testing of the pilot testing of the app with HIV care providers. And we did that. And what we based this pilot testing is inviting them on 3 sessions where they will have the opportunity to test the app 3 times. And we also conducted a qualitative interview at the end to just get to know from them their acceptability of this new digital tool. And this is how we tested the Decision T, which is basically a decision-making algorithm. The app is telling you, is this a patient smoking? Yes. And then is the patient able to swallow? No. Oh, then this patient is more likely to use nicotine patches. They won't be able to use anti-tobacco medication that it needs to be administered orally, and so on. So the app is really guiding you, and it has also sentences that you can use to start the communication with that patient. Particularly, for example, if the individual even is not smoking. Are you a smoker? No. Wonderful. This is great. You should continue being smoke-free. What about your family members? Have you been exposed to secondhand smoking? So it's a way of initiating that conversation that won't take more than 4 minutes, and you will see the results. Next. So this is the average time, 5 minutes, 17 seconds is the average time. But what we saw in the 3 tryouts of these testers is that each time that they were testing the app, the time was getting reduced because they know how to use the app now. The accuracy, what they recommend in terms of counseling and the pharmacotherapy was 90% the same as a tobacco specialist would advise to a smoker. And then the usability, we use a scale, a very well-known scale, which is the System Usability Scale for digital tools. And if you have more than 75% of the score, it tells you that the tool is usable, that is friendly, that they don't need technical support to manage the app. So we got 88%. So that was the quantitative aspect of that smartphone application. And you can see those 2 quotes from providers where they said, well, everything is in the app. I have it on my phone. I'm equipped now to provide smoking cessation services. And you can find more of those results in the publication that you have on your right. Next, please. And just as a wrap up, we got 2 internal, one internal funding, another external funding, and the app was, we continue pilot testing. So we pilot tested with dental care providers successfully. We pilot tested with cancer care providers successfully. We pilot tested with primary care providers. So this is an app that can work with any type of providers in any setting. And the other thing is that we developed this app in English because of the COVID pandemic and that the fact that I needed to test it in the US. But we are, as we speak, translating and culturally adapting the app into Spanish language with the intention, and with some of you, I already talked to test it with some of the SWOG Cancer Center and see how that works in our region. So thank you so much, and I look forward to continue the conversation on cancer prevention. I am delighted to see that you are making space for cancer prevention. Thank you.
Irene, I mean, extraordinary work and clearly things that can help us as clinicians, make a difference. We have time for one question.
Hi, Irena. I'm not sure you can address this, but there have been recent reports that like the cigarettes, especially e-cigarettes being sold, have like up to 6 times the levels recommended by the FDA, yet they're available in stores. How does that affect like prevention efforts?
It's hard. It's hard, particularly because what Dr. Barnoya said before is the marketing of the tobacco industry on trying to pose electronic cigarettes as a healthier alternative compared to cigarette is there, and people think that by not smoking regular cigars and using electronic cigarettes, they are avoiding the damage that can cause. I'm a dentist, and there are even reports of the local damage in the oral cavity and the pharyngia of all the vapes from the electronic cigarette. And yes, it's a starting there is no long term of publication, but it's still, I think, already relevant and indicated that we should come strong in terms of preventive and control measurements for any type of tobacco product. All right. Thank you so much.
Thank you. Fantastic. And we are going to invite next to Dr. Mauricio Cuello for the next talk. He's our principal investigator in Uruguay. He's a recognized medical oncologist in his country. He's the academic director and the coordinator of the thoracic oncology unit in the Hospital de Clínicas Montevideo. He's also the coordinator of the Uruguayan Cooperative Group. And for those of you that were part of our meeting last year, he and his team were extraordinary hosts for our academic conference last year. Mauricio, pleasure having you here.
Thank you very much for, thank you very much for the invitation to speak about the impact of smoking-related cancers in Uruguay. It's a very interesting topic and a challenge for us. Not working?
I'm not sure this.
Try pointing that
Okay.
way.
Disclosure. Well, I will approach to a very short epidemiological aspect, and then I will use a couple of local and regional challenges in screening and access care in particular. Well, as everybody knows, at least 20 cancers are clearly associated to smoking. This is lung cancer is the big killer, but the head and neck cancer also is very well associated. Also, in gastrointestinal tumors and tract urinary tumors, we have a strong evidence in favor of the smoking like a risk factor. Cervix cancer has a very clear risk factor, that's HPV, but also smoking is related. And other less frequent tumors are also associated to smoke. I think that I said it before, but if you want to understand Uruguay in numbers, we are a very little country. When we want a fast vision, we are, you need to divide the incidence or the mortality in US for any tumor between 100, and you get the number in Uruguay. And our population is similar to the Nevada state, and Montevideo has the same population that has Las Vegas. We have also casinos and marijuana, but not lower taxes because nothing is perfect. As you can see in Uruguay, when we use age standardized mortality rates, we are in the blue group for lung cancer. That's the same mortality that's in US. Canada and also Cuba has the same number, similar numbers. It's about in men's or in globally it's about 32%, and then Argentina and other countries is nearly 20 and 18 the number of age estimated rates of cancer. In women in Uruguay, the principal cause of death is breast cancer, but the national registry say that in 10 years, they will occupy the first place. And recently, in the 2022, two meta-analysis has associated strongly also smoking with breast cancer, increasing the risk in 10%. Initially, in the first trials, our investigators proposed that smoking could be protector in front of breast cancer. This is the list in mindset incident mortality in Uruguay. You can see the same. Lung cancer is the 40.86 in mortality, then prostate and colorectal. Together, they are the cause of death in 70% of the cancer in Uruguay. And in women, you can see also that lung cancer is right now the second in cause of mortality, and it's very similar with another countries, with the exception of cervix, that we had a high incidence that is not related with our income. But I want to describe our fight against smoking in Uruguay. We started in 2004 with the Framework Convention on Tobacco Control. And in 2005, Tabaré Vázquez, that was an oncologist and president of Uruguay, he started and promote a new law in 2008. This was a very important law because modified the marketing in Uruguay. You can sell tobacco, the companies, but the branch can use only one product. You can get a light, blue cigarettes, or any one of difference. This branch is unique. And the box, the packaging, need to include an image that covers 80% of the box in the front and the back. When we tried to implement the law in 2009 and 10, the Philip Morris started a lawsuit that I think that was 8 years. And in this period, we didn't progress in increase the rules. They asked us for 5 times the budget we use to treat the consequence of smoking. This was a very important lawsuit because several countries were awaiting during years to start their own policies, waiting for the result. We won, and then in the next year, we introduced new laws and rules. We start the play packaging after the lawsuit, and during the last 2 years, another red flag, because the new government introduced a laws that with flexibilization in packaging and also in electronic heated tobacco. My grandfather said me that when we can understand something, because these laws has a very, very high approval from the population, very high, but they change the rules, the government changed the rules. When we can understand something, follow the money. The tobacco companies were the principal sponsorship of the campaign of the president, and it's explained the lobby and the change. The School of Medicine, together with the scientific societies and also a strong support of the population, start a lawsuit against the government. We won, and they stopped the law. This is the smoking prevalence in Uruguay after start these new measures in the last 15 years. And you can see clearly the impact in men's and also in women's. This number, 20% is very hard to modify with only with policies. You need to increase the economical conditions, educational aspect that need to be modified to law. But I am optimistic because in teenagers, we had a 9% of prevalence in tobacco. In marijuana, between 15 and 18 in Uruguay, 100% had tested and 70% consumed at least once a week. It's a very important problem that needs to be integrated on research in our studies. We have a challenge in smoke cessation. If we stop smoke cessation programs, the tobacco back. We end fighting against tobacco. And right now we have an important pressure about screening. I don't know why. Probably if I follow the method of my grandfather, I will understand why. But in Latin America, it's very strong the pressure to implement lung cancer screening. And also a challenge in access and quality of care. Lung cancer screening has a very good marketing. The system in Latin America, also in Uruguay, I have pressure to reproduce the two trials, the Nelson and the American trial. The adherence is very low. It's 1 in 8. It's for a program or for a national program of screening. It's impossible to reproduce the numbers that they get in the trials. And the promise of a screening is reduce 20% the mortality in the group that receive the screening. But what happened in the real life? Is it possible? Most of my colleagues see me like the Grinch of screening. Sorry, it's hard to believe, but I'm not against screening, okay? I think that we need to adapt to the reality and our conditions. It's a question of magnitudes. It's the best choice for us, resource, cost effectivity. I'm sure that we need to generate local evidence about the benefit before to develop any new program. In Uruguay, with 3.5 million of people, right now we're running three programs by different associations and hospitals. It's like a shock, but to show the magnitudes. If Uruguay, suppose that in Uruguay, the service of radiology work like the engineers in F1, okay? And they can make scans without stop, 7 days, 24 hours, all the time during the year. Okay, they can produce below these conditions nearly 26,000 CT scans. In the real life, they produce 8,000 a year. If you use the inclusion criteria that are recommended in US, for example, we have 200,000 candidates to lung cancer screening. If we incorporate 1% per year in the round 3, when you have the 3 generations together in a year, you will need 7,500 screening CT scans. And also, you need to add the 15% of the patients that will need diagnostic CT scans, function below CT scans. And it's a number that is, if you increase to 20%, we will need this 150,000 scans per year. It's about working in this way. It's about CT scans only working in lung cancer screening accounts. Well, Uruguay has certified CT scanners. It's a low number? No, it's the recommended number. It's the same number that has Canada and Israel. Mexico has 7. This number is the OECD. Probably they could increase with the pandemic, but it's very similar. And we have a spectacular scarcity of human resources. Quality of lung cancer screening is $66,000 versus $8 of the smoke cessation. It's easy to an administrator put the target in, but the pressure is to install the lung cancer screening. I repeat, I'm open to test and trial new methods, but we need to define another population with another characteristics, be more specific, and probably we need to change the schedule of CTs. Another challenge. Impact of clinical practical gaps on the implementation of personalized medicine in advancing non-small cell lung cancer. Personalized medicine has a direct impact because show us our miseries. It's very This study is in US, 2022. They studied 500,000 of patients with the diagnosis of lung cancer. Only 64% can get a benefit for care option appropriate for the disease, and will likely have suboptimal outcomes. It's an important crisis. The pandemic here is the problems with care access. The problem here is with the care fragmentation. We need to, sorry. In Uruguay, we cover without copayment, zero copayment. First generation TKI inhibitor receive only 20% of the patients that need to receive this therapy. Pembrolizumab in PD-L1, more than 50%, only 18% of the patients. We have several clinical, 50% of the patients were not tested, 50%. And 20% failed to get an oncologist. Uruguay has one oncologist for every 130 new cases that year. It's a European recommendation. It's a very good number, but 20% of the population with lung cancer never get a visit. The problem is care fragmentation. I think that these two areas are very important, and it's an open place to work together in the context of the life. As I say, we need to adapt the recommendations to our epidemiological resource reality, but based in research. Because if we live in the hands of administrators, the decision will be based in the business. And we need with our response. Develop research and access to care and quality of care is urgent in Latam. We don't have navigation. It's very few centers have very good programs of navigations. Patient advocacy practice that doesn't exist in Uruguay. And if we want to lower the burden of disease, it depends directly on the success of smoke cessation strategies. Both the principal trials in CT screening, they didn't include smoke cessation strategies. I think that we need to rethink in new approach to prevent smoking related tumors, and we never can stop the smoking cessation politics. Thank you.
Thank you, Mauricio. If there was like one quick question, we may have time for that. Well, thank you so much. Very interesting to really hear about what we should be doing, or what, data can show us in certain countries, but how to really, as you said, adapt to the reality of each place based on science and evidence. The last speaker from this first part of our symposium is Dr. Luis Cabrera. He is the new chief or head of the thoracic oncology department at the National Cancer Institute in Mexico. He is going to talk to us about lung cancer treatment in Hispanic patients. So welcome to SWOG. It's the first time that he's joining us. We hope that this means more collaborations. He's here initially representing Dr. Oscar Arrieta, the new director of the NCI Mexico that had some last minute. So thank you so much for joining us, and we hope to see you here much more.
Thank you for the presentation. I will begin with this topic, that is the treatment of lung cancer in Hispanic patients. First, we have to see what happened in Latin America. We are a large region with about 600 million people in over 20 countries. That is around 8.2% of the world populations. There is a heterogeneity in the GDP, poverty, and income distribution among Latin America countries. There's a significant difference in healthcare systems among and within countries, but in the most of the case, there exists a low GDP health expenditure, fragment healthcare system, and incomplete coverage. The socioeconomic, geographic environment, and ethnic factors strongly influence the patient presentations, diagnosis, and management for lung cancer patients. There are some differences between the regions in Latin America. For example, in Central America, the rates of incidence and mortality for lung cancer are low. They don't appear in the top 5 on most mortality cancer. And is this difference between South America, for example, that we see in the last presentation, countries like Uruguay or Argentina have a high incidence and mortality rates for lung cancer. Another difference comes for gender. For example, mortality rates among males decrease with greater declines in Mexico and Costa Rica, but for females, for example, mortality trends increase in some countries like Uruguay and Brazil, and others like Cuba or Ecuador and Colombia is stable in the last 10 years. We know that most of, or the most important factor for prognosis of patients with lung cancer is the stage of the disease of diagnosis. But unfortunately, 60% of the patients with lung cancer have late stage disease at diagnosis. That is impacting the prognosis of this patient. The 5-year relative survival, for example, for patients with metastatic disease is less than 10%. This can be different in different countries. For example, in this table, I show the difference in the stage of presentations in countries like Brazil, United Kingdom, and Mexico. And we can see that patients with limited stage, for example, in Brazil is around 50%, and in United Kingdom, 22%. But in Mexico, unfortunately, it's less than 1% that is reported that the patient present most with metastatic disease. This is because we have a low referral to hospitals that have enough resource for treatment these patients. For lung cancer, it's important to look for the difference in the risk factors that we have in Latin America. One of the most important is the smoking. Cancer cases related to tobacco are increasing both genders. In some regions, the smoking rate steadily declined between 2010 and 2018, but some countries in Latin America still have a high smoking rate, like Cuba, Chile, or Argentina. Only few countries have effective anti-tobacco campaigns that differ. For example, in Mexico, there has been a significant increase in taxes on tobacco products, along with great restriction of smoking in public space. There is also a ban on tobacco advertisements in the media, and this measure has been effective in reduce the smoking rate in Mexico. I think that is the goal to diminish the rate of lung cancer in our population. Another important risk factor that we can see in Latin America, still the good smoke exposures, because some countries is a high risk factor like Peru, Bolivia, Paraguay, and Mexico. And another important thing for this risk factor is that the association of this factor with the histologic of adenocarcinoma and the presence of EGFR mutated, since 50% of the patients with this risk factor will have the EGFR mutation. This is why in some of the regions of our in Latin America, the increased rate of these alterations. We know now that it's not only important to divide the lung cancer by histologic, the most important is to make the molecular studies, because half of the patients maybe have the opportunity to be treated with target therapy. This target therapy finally will impact in the prognosis of these patients. He can see that patients that only treat with chemotherapy, the median overall survival is around 12 months. For these patients, when you treat with target therapy, it could be increased to more than 30 months of survival. Another thing that is related to the risk factors is the known that each risk factor could be a impact in the molecular characteristic of these patients. For example, for patients with history of smoking, they have more prevalence in alteration like KRAS or high tumor mutation burden. This means that this patient could be tried more effective with treatment like immunotherapy, but in contrast, patients that don't have the history or have history of good smoke have more frequent alteration in EGFR or LIK. This is a map that shows the percentage of alterations between all the countries in Latin America. In general, the prevalence of some alteration like EGFR or LIK are more high than in other regions of the world like North America or Europe. But there are some difference between most countries in Latin America. For example, Mexico and Peru have a high frequency of EGFR alterations. More than 30% of the patients with adenocarcinoma have this mutation. This most could be for the risk factors that have. In Mexico, they don't have a high rate of smoking history, but we are exposed to more good smoke like a risk factor. Another important reason that could impact is the genetic ancestry that contribute to somatic mutation. We can see that in some populations, like the East Asian population, the rates of mutation like EGFR are increasing. About 40 to 5% of the patients have EGFR alteration. At this sense, more equal that it could have in some countries in Latin America. Now I will point only to one of the two most important barriers that we have to access to treatment in Latin America. One is the challenge in molecular testing because exists a widespread access of molecular testing. Molecular testing facilities are limited to refer hospital, academic centers, and large private laboratories. And there is an impact of molecular tests on target therapy on healthcare costs. This is a challenge in the world, and it's a very big challenge in developing countries. We need more extensive and inclusive epidemiology studies because we have to know the geographic variation, the range of the driver mutation, and we need more quality control because we need more regional committees to provide regional validation and certification. Some of the barriers that we present for biomarker testing in Latin America is the limited access of the target therapy, reimbursement of the testing, the tissue sample quality, turnaround time for test results, and coordination among the multiple specialist groups. Another point is the research in Latin America, because cancer research is disproportional focus on high-income nations. Only 8% of the research clinical trials were available in limited income countries. Low levels of investment in cancer research is a significant barrier to local initiatives. There's a limited number of cancer specialists and lack of formal training in research procedures. And there's a delay in research regular process. For example, it could be last from 3 to 6 months to obtain and study approval. And in approximately 10% of the case could last more than 1 year. This impacts the important form the research that we report. Another point is that the research that is made in Latin America is concentrated only a few of countries. The most are reported in countries like Brazil, Argentina, Mexico, and Peru. Despite these barriers, Latin America is still a very attractive region for research due to their unique cancer epidemiology, a high population density, a large ethnic and genetic diversity of the population, relative low cost of the most procedures, and a high potential for patient recruitment. To improve the research, we have to generate regional and international collaboration programs. We have to simplify progress and short timelines for regulatory authorities to propose research to evaluate epidemiologically important topics for the regions and to improve access to the clinical cancer treatment and increase funding to clinical research. And other things is that conclusion, lung cancer are diagnosed at late stage in Latin America because cancer screen in LATAM and treatment for late stage cancer in public hospital with limited resource are very low. There exists a lack cancer care planning strategies. We have limited access to molecular testing, modern standing procedures, and target therapy. We have to focus on the vulnerable population due to a geographical, educational, and economics barrier in the access of cancer treatment, early detection, and palliative care. One example that I have to comment is that in the Cancer National Institute in Mexico, we have the first early detection program of lung cancer called Detecto. This program includes patients or individuals with similar risk factors as other studies, such as Nelson study, but also takes a factor specific to our population, such as exposure to good smoke or family history. And we only have 1 year, but with the detection, we had detect 4 patients at early disease in the first 500 screening. This is a better rate compared with has been described in other studies. This leads us to believe in the need to continue implementing these types of programs in populations like ours to determine their impact on the incidence of lung cancer. I agree with the last presentation that I think that the better option to decrease the rate of lung cancer is with the anti-tobacco strategic more than with the screening strategy. Thank you.
That was an extraordinary overview and very interesting to see all those differences in the proportion of EGFR mutations. I have a quick question for you. So I understand how the issue of molecular testing can be, huge in Latin America. But if you had access to the test, will you have access to the drugs that you need? Because, it's a conundrum. If is it enough knowing, or we, in addition of knowing, need to be able to have those drugs? Do we have access to those, at least in Mexico?
Yes, no, I think that is a good question because unfortunately, in countries like Mexico, we don't have access for the treatment for all the patients. But I think that have the information of the molecular characteristics of our population could help us to make more strategies that are more important in our country, depending on the needs that we have for each mutation. For example, in Mexico, that we have more patients with EGFR, we have a government program that could give more access for TKI, like TKI of first generations, that the cost when they buy in a lot of, or in a more extensive population, we could have more access for this treatment and maybe pay more attention for this kind of treatments instead of other treatments that are less frequent in our population. And another is the access that the research permits to our population. I think that increase the research is an opportunity for treat more patients in countries like ours.
Thank you. Absolutely. How information can help us drive, healthcare decisions. So thank you so much. I think we have just one question for the panel, and I don't know, maybe Irene could be, a person that helps us answer this question that came online. Of course, congratulations to all of you, but they're wondering how to approach or start conversations for smoking cessation specifically in Latina women in the United States. Any insights based on your work? There's, understanding that maybe different backgrounds of Latinas can have different perceptions, but clearly I need like Latin ed, not Latina. I was thinking that was an A, but anyway, in Latinos, Latinas, Latine.
Sure. One of the issues is, well, there are several issues for the Latino population in the U.S. One of them is that Latinos in the U.S. don't.
You touch the microphone.
Sure. Latinos in the U.S. don't smoke the same as other race or ethnicities. We smoke. We are what we are called intermittent smokers. We don't smoke every day, which makes very hard to implement smoking cessation strategies. The other thing is that we tend to underreport heavily because we don't think that smoking over the weekend, we are social smokers, then it's difficult to capture. Then there is this other layer, and I published a paper almost 7 years back about the names of the products. For Venezuelans, we call cigarro the cigar. For Mexican, cigarro can be the cigarette. So can you imagine in the National Health Service that are completed in the US, we are not really sure about the reporting. If the different, because in Texas, most of the population, the Hispanic population is descended from Mexican. In Miami is Cubans mostly. In DC is El Salvador mostly. So we are, we can change quite a bit the way how we name different products. So responding precisely on your question, this is an important group that needs to be addressed because the impact, even as intermittent smoker into health, is heavy. And then there is also another cultural layer, which is in cancer treatment. How punishable is the family and the caregiver to that smoker who is being treated for cancer, in the sense that, oh, you did this to yourself. Are you going to smoke again? Or with my partner is the one going through smoking cessation, but I will continue smoking because you are the one dealing with the cancer treatment or whatever. So we need to repackage the interventions and tailor for the Latino population. Hopefully our collective efforts will respond to that. And I think it's a great opportunity for the efforts that we do in Latin America. So in the US, we could apply those efforts for the Latino population in the US. And it's how I see the global local synergistic approach for this problem. Thank you.
Thank you. And with this, we conclude our first part of the symposium. And I think it was a great way to see how important these medical problems are in the region and some of the factors that contribute to it and the relevance of smoking cessation. Of course, what we're going to do is now have this counterpart in terms of what are we doing at SWOG and what are potential ways for us to collaborate. And for that, We are very pleased and honored to have Dr. An Chiang with us today. She's the executive officer for the Lung, Breast, and Immunotherapies committees. She's been a supporter of our program. She's an associate professor of medicine in the section of medical oncology. She specializes in thoracic oncology. She has a specific interest and background in translational research and metastases. Great extensive experience in clinical practice. She practices at Yale University, and she's going to talk to us a little bit about the Lung Committee and the opportunities. Thank you so much for joining us.
Thank you so much for having me, and especially for the lineup. I've already learned so much. My head is spinning from all those products that are available, and then also thinking about the different accessibility and health issues in different countries in Latin America. So why get involved in cooperative groups? And I think this is, I think this is important for me to remember, and I wanted to start with this because I think cooperative groups allow us to really network with our multidisciplinary colleagues across the nations, and I hopefully across the globe. I think that there are really great opportunities to discuss and design clinical trials, and I'll put that to you to the end to really think about strategies to develop trials that we can run in Latin America. There are great opportunities for mentorship, funding, and education, as well as the impact of all of those on us all and on researchers and patients. Then there are opportunities for publication, and then the cooperative groups give great access for researchers to fantastic patient advocates. And there's really been a focus on DEI and including other underrepresented populations. So how to, and actually I had a picture and I wasn't able to get it into my talk, but I spoke at this, the Latin American Symposium back in April of 22. And I think it was shortly after both Mariana and I had joined as executive officers. So I had a great picture of that, and I'll send it back to you. Yes. And that was, I don't know, were any of you at that meeting? It was right as we were coming out of COVID in Seattle. Yeah. Yeah, I think it's great because I had the opportunity to reflect upon some of the progress that has been made since then. And I think a lot of leadership through Mariana's leadership, thank you, and Dacia as well. So how do you get involved in the Lung Committee? And that was the question, that was what I was asked to talk about today. There is an open door policy or an open Zoom policy, I guess nowadays, with the Lung Committee leadership. And Janelle Gray has been fantastic as Lung Committee chair. I'm always open to talk to Roy Herbst. It's a little bit busier, but also very available. And I think that if any of you are interested in specific trials or having more opportunities to participate in some of the translational research or any of the research that's going on, that would be the first thing that I would suggest, is just send an email and then we'll set up a meeting. The group meetings are fantastic, and I'll show you what we have on deck for Saturday morning for our Lung Committee. And I think there are opportunities to actually talk to folks in terms of developing new studies. I think that's really the beauty of SWOG, is that you have young, old, senior, mid, everybody in the same room and really open, listening to each other in terms of, what are good ideas or what ideas don't work. And so I would encourage you to come to the committees to engage in that discussion. There are lots of opportunities to serve as investigators and champions of SWOG studies. I think that, we'll talk a little bit later about some of the issues, some of the barriers around Latin America, but I don't think that those are insurmountable. And actually there have been, and we'll talk about the trials that are open and actively accruing now. Obviously the ability to accrue patients, and then there are these translational medicine efforts. And I think that, looking at that, that slide on EGFR frequency in different parts of Latin America already has me thinking about how can we utilize that information and how can we learn more about the biology of EGFR disease, for example. This is the lung committee. So Janelle Gray and Roy Herbst are the chair and vice chair. Mary Redmond is the statistician. And there are lots of, under Janelle's leadership, there are lots of different active committees. And I will also, I don't think I added on here, but for example, there's a lot of interest in neuroendocrine tumors. And so Nagla Karim approached Janelle and said, you know, gee, we're really interested in developing some of those trials. And so that has been an offshoot that's been very successful in developing several concepts. So again, lots of ways to plug in early stage, locally advanced, metastatic, surgery, imaging, et cetera. Our lung working group and committee, we meet twice yearly in person at SWOG, hybrid availability, and we have regular Zoom calls where we're talking about those new concepts and developing them. And that's where you really have the opportunity to get into, you know, how is the pizza made there? We need everybody's help for this. And then you go through the system of activating the concepts and getting them going. This is Saturday's agenda. So John Haymack is going to speak about the Aegean trial. That's the perioperative, both neoadjuvant and adjuvant IO trial. And there's going to be a debate. So there's going to be a debate with Doctors Goldberg and Gibney talking about pro-perioperative, and Khan is arguing for adjuvant chemo, and there's going to be a great Q&A panel. So hope to have. How many of you see lung cancer? I know some of our speakers do. Anybody else? I see you. Excellent. So hope to see you there. And so now I'd like to go into our portfolio. So these are our active studies now. And I also wanted to give some updates to you on the results of Pragmatica and where we are with the Insignia trial. So that's in the red box. So the Pragmatica lung came from the lung master protocol. Oops. And this is basically the lung map is for second line patients, and the idea is to do biomarker driven therapies. So do the sequencing and look to see which mutations are present, and if there's a specific mutation, then you can go on that particular biomarker driven therapy. And then there was a non-matched arm for everybody who didn't have a mutation. And so the study that led to and this is just the latest in terms of which are open. So the study that led to the Pragmatica trial that I'm going to mention is S1800A. And so for these patients, they were randomized to docetaxel and ramucirumab versus the standard of care investigator's choice. And so this was the unmatched arm. If you didn't have any mutations, you could go onto this trial and go either to standard of care or docetaxel. And this was a positive trial. So the median overall survival for docetaxel was 14.5 versus 11.6 months, hazard ratio of 0.69. And so this has led to a phase 3 trial called Pragmatica Lung. And we're really excited about this trial, not only because it's accruing like gangbusters, but this is a pragmatic trial. And so what do I mean by that? It means that all those things that you collect, like labs and imaging and all of those, we are not collecting. We're just looking at overall survival. So coming out of COVID, and somebody mentioned that before, we know that clinical trials have suffered. So how can we help our sites and make these trials as easy as possible? Patients are going on to investigator choice or docetaxel, and the only thing that we're collecting is overall survival. serious adverse events. So that are related. So in the short time, first of all, this protocol was unheard of. It's 20 pages. And many of you know that our average protocols are in the 100, 200 page range. And so it was activated in an incredibly incredibly quickly because of actions by the FDA and other folks to really cooperate and collaborate to say, this is important, let's open it. And since we've opened, it's really exceeded our expectations in terms of accruals. I think we have 140 and we've only been open for a few months. So definitely completely exceeded. Interestingly, culture-wise, the sites are calling us and they say, well, don't you want this? And we're like, no, we don't want that. So they say, but are you sure you don't want these labs? And so it's really a different way of doing things, which in this case is really focusing on overall survival. We think that's the endpoint that's going to be the most important to our patients. So that is the pragmatic trial lung. And then this is the Insignia trial, which is the trial that I'm co-chair. This is first line metastatic for PD-L1 positive. And this is a sequencing study. So you either are randomized into monotherapy pembrolizumab, and then if you progress, you go on to chemo, or monotherapy pembrolizumab. If you progress, we add chemo. So that's a really important question, that chemo post-progression, can we actually cause cytoreduction and release of neoantigens that might actually help to boost the immune system? And then our control arm, the carbo-pembro. And we are really close to finishing accrual, 562 out of 600. So this is too late for you guys to participate, even though we did talk about it in a year and a half ago. But again, let's talk more about the trials that we can run in your countries. The active studies, one of these, so the S1827, there are 3 Latin American sites that are activated, and 2 of you are already enrolling. This is a phase 3 study of surveillance MR with or without prophylactic cranial radiation for small cell. So thank you for opening this. Thank you for enrolling. I know a lot of work has been going on into this, and I think that, we really appreciate the help here. I think it'll be important to answer a really important question for these small cell patients. So what's coming in development? Well, I think that one thing is that we are really thinking in the lung committee about Latin America earlier on, not just after it's all designed and whether or not you can activate it, but Dacia is there in our meetings, with that last meeting that we have, and we are asking at every concept development meeting, I think there is an actual question on the form that says, have you considered Latin America, and why not? So we're talking about that. And I think what's coming out of that is that we're actually more aware of some of the barriers and more aware of, how can we design these things in a way that will be more accessible for everybody. So the 2 trials down here, I think I wanted to ask you about and just get your input. I mean, these are relatively early on. They do have a SWOG number. That means that they've been approved by our internal SWOG triage committee. But I wanted to ask you whether or not you would be interested in these types of trials, or if they would be, what kind of barriers, and if it would be something that is of interest. So the first one is 2410, and that's a phase 2 randomized PD-L1 versus iademstat, an LSD1 inhibitor. And this is versus investigator's choice of standard of care for second line extensive stage. I can imagine after the presentations today that there may be issues in getting the standard of care drug. But this is one that we have, identified as something that we wanted to see and explore. What are the barriers? And if not this trial, understanding what in the future we could do. So that's the first one. The second one is a randomized phase 3 study of durvalumab versus observation following neoadjuvant chemoimmunotherapy. So those patients, this is actually, so there's a pair of trials going through together with SWOG and ECOG, and it's basically giving chemo IO before surgery. And then if you have a PCR, that's the SWOG cohort. We study you and learn a lot from the information I'm getting. Like 1 minute. Okay. And then the other is if you don't have a PCR. So think about those, and I'd love for you to come up to me afterwards or email me and just give me your ideas on what you think. No, that we would never be able to open up this trial, or yeah, we would be interested. Let's explore it. The publication updates I will go through. They'll be there with the slides for your review, and I'll just end with this. So next steps. Number one, we're considering international participation earlier. So I think that's really important. We are continuing to understand barrier, the drug access, who has a IND matters, standard of care differences between countries, specimen processing times, availability for molecular testing. These are all things that are I think they're not going to get solved if we don't talk about them. And I think that if we take step by step, we can learn how to do this, hopefully. And then that last bullet is what I would ask you with is, how can we really design specific trials with the Latin American sites and the underserved populations with your participation as one of the key goals. So thank you very much.
Thank you. I think this was very informative and hopefully can, have you thinking about for our colleagues in Latin America ways to collaborate and do it early on as we learn more about our barriers. Thank you. Now to keep the agenda on time, the next part and final of our meeting is going to be now like going a little deeper into the activities of each one of our sites. And what we have done over the last couple of symposiums is everybody's going to do like a super short update, but we're going to go a little deeper in one of the sites. It's not going to be that deep because we only have 10 minutes, but this seminar, it's the time of Peru to tell us a little bit about their work and give us a sense of all the great activities that they are doing over there. So for that, we're honored to have Dr. Tatiana Vidaurre with us. She's the SWOG PI for Peru, and she's been involved with our program for many years. She actually is the former director of the Instituto Nacional de Enfermedades Neoplásicas, the equivalent of NCI in Peru. And at that time, when she was the director, I think that's when the initial agreement with Peru was signed. So thank you so much. It's great having you back. And go ahead.
Thank you, Dr. Mariana and Darcy, for this opportunity and to be here in this meeting. I think that I can show the institute. This is the National Cancer Institute in Peru. It's a important institution starting in 1939. And the main role of the institute is promote the prevention and cancer control around the country. And now, since 2006, is the national agency for policymaker, for technical operation, and for education and research, or promote education and research in cancer control. In this issue, for this issue, INEN is now the head of the National Oncology Network, including the highly specialized professionals, and to promote care, oncology care, early detection, diagnostic treatment, and all types of cancers. And in the last years, at least 10 years ago, starting this development to innovation and technology, promoting the National Cancer Plan through government supporting. And that plan was called Plan Esperanza. That is why INEN can develop a network, not only a national level, this network is the international level. This network is for research, for collaboration, not only for cooperative group, is for founded, for research through the Peruvian government, Concitec, Prociencias, Innovated Peruvian, and World Bank. And we had a long time collaboration with important institutions like Europe, the Research Institute in French, and MD Anderson Cancer Center. That is the last one collaboration is with Dr. Irena Tami, and with Southwest Oncology group, of course. This is the studies. We had some barriers in the last years, but now we are new achievement. We have new achievement. The new protocols we are open, they are ongoing. We treat patients enrolled. We have 2 new approvals, and we expect to enroll many patients in the next years. About the lung cancer, I have to say thankful Dr. Luis Mas to support me with this presentation. And we had the same problem that you heard before in the presentation in Latin America. But I think that the main case is that these problems will lead in the last years in many ways, because at least the consumer of tobacco smokers decreased 10%, but we had the many another issues to have to lead. 30% of the adult population is in Peru is yet smokers, and this problem affects a little more to women, adolescent women, and we have 6 regions in our country that have a 25% of smokers. And for this intervention, we are starting in about 1993 with the regulation by laws that we had long time in this intervention. And the evaluation of in the whole reports, we have a strength tobacco control monitoring, protect people from smoke of the tobacco, offer help to quit tobacco. We don't have, it's like the cessation program. Warns about the dangers of tobacco we have, but enforces tobacco advertising and promotion bans, also the compliance of the law. We have quit intervention, and increased tobacco takes we don't have that intervention. Even we have a good regulation. Another thing is about the quality of the cooking in the families in the Andean Mountain. They cook it by burning biomass. For this, we improve cooking programs to this problem was decreasing in the last years. And another thing is personalized medicines in oncology, for oncology and lung cancer. In this case, we implement molecular testing, and we have a small number of geneticists, doctors or pathologists, specialists. We could implement at least in the important institutes. Now we have a new opportunity that is the National Cancer Law, that we believe that promoting tissue banks and research in molecular oncology, we can expand our system. And with these different centers around the country too, that is a specialized center with expansion, the model and comprehensive oncology centers, we can have more opportunity far away in the country. Approval drugs for use and access in lung cancer for the government. We have this drug in approval, difficult to access for all patients. And this is the protocols that in the institute we have in lung cancer. And since that is all for this presentation. Thank you so much.
Thank you, Tatiana. I don't know if anybody has any quick comments for Dr. Vidaurre. Okay, so what we're gonna do now is just go country by country, hearing a little bit about some updates or anti-tobacco measures and lung cancer. In person today, it's Dr. Javier Tamales, who's gonna give us a quick overview of the work in Chile.
Thank you. Nice to see you, everyone. Deisha told me 5 slides, so here we go. Sorry. Okay. So regarding our numbers, is this working? Okay. Regarding our numbers in Chile, you are looking right there. Over 60,000 deaths from lung diseases, and 52 people die every day due to smoking-related diseases. So this established the whole regulatory framework for tobacco in Chile. Unfortunately, the numbers are getting better, showing a decline in tobacco use from 40% to 30%, and a new approach about the label of the package. I don't know if you're seeing right there that every package now shows a really ugly picture of. I don't feel really good about this because this package is showing a picture of a real patient who volunteered to show his case, but in the end, actually resulted in lower tobacco consumption in Chile. Regarding the national framework for this, we have 2 separate components: the primary care level intervention and the healthcare provider empowering initiative. The primary care level intervention are specific primary care resources to establish tobacco control approaches. And the empowering healthcare providers include specific training, not for physicians, but different people that work in different communities and different centers, not necessarily healthcare centers. And the objective of those is to offer a very fast and focused training of 15 hours to make awareness in communities to reduce tobacco use. And regarding my sites, the tobacco control program, we have a specialized anti-smoking team. It's not a very big team, but they are really, really nice people working with a lot of patients, as you will see. And they have these structured therapeutic sessions. There are weekly, between 8 to 12 weekly sessions with focus group of 10 patients that are supporting between themselves. And they offer behavioral therapy, motivational interviewing, and bupropion as well. We only have bupropion as medication for this. And we have follow-up, and they design their own tracking system for the cases to try to rescue the patients that drop the program. And as you will see, they are, since 2018, they have seen more than 300 patients, and they have a really, really good adherence now, thanks to this platform. And basically that, the age mean is 55 years old, and this is kind of a very special population, as you will see right there. It represents that almost 40% of women participating in this context was pregnant and wouldn't wouldn't quit smoking during pregnancy. The good thing is almost 60% of those women, in fact, says the tobacco consumption. So I think we need to be very respectful of these numbers because they represent a really, really bad population, you know, like pregnancy smokers and cancer patients. The other good thing of this approach that includes a CT scan, a thoracic CT scan. So any nodule is rapidly referred to as a thoracic surgeon. So this is the final slide. We have a very multifaceted approach regarding all of this initiative from the national level, institutional level, and in my site. We are still continuing the implementation of anti-smoking programs at different levels to address national, community, and institutional level. And just a small slide of the status of the trials we are running. We just got a National Health Agency approval for use of carvedilol for the S1501. So we have hopefully we'll be able to open very soon. The S1714, we enrolled 10 patients that are still on follow-up. The S1802, well, it was very important for us because we require a really hard credentialing process. You know the story of the head phantom. I don't know if you remember, but we in the end we opened this trial, and like two months ago we have already enrolled 1 patient per month. That was more than I was expecting. So yeah, it's a good thing because this is a very specific metastatic prostate cancer population. So they are not easy to find, but still we have enrolled 2 patients. The S1827, we are just looking forward to activate it, even though we don't have an MRI in our center. We have now we are working on credentialized and private imaging provider, and they agree with that in order to have the quality of the imaging that the study requires. And the S2010, I think we'll be opening that trial soon, but there are some concerns regarding the participation of that in the intervention arm because it requires an email access, and not a lot of people in Chile uses their email so much. So we are still trying to figure out what is the best course of action. We have some proposals regarding this. I don't think I have the time to discuss it right now, but I hopefully want to use this meeting to have a solution because we really want to participate in this. And the S2013, we have it open. We have enrolled 4 patients. And yeah, it sounds good for us because nivolumab, for example, is not covered for our basic coverage. So still, we are enrolling patients through other costs contention strategies for the participants. We are probably open very soon. The TEMIS trial, we already accepted. We have to, this was very difficult because we had to change the informed consent form because it was very tough with the, I think it was very tough with the patient because the way it was written, it was like hostile with our patients. Our patients, you know, our people didn't like this. So it took us like 6 months to get approval from microgacrin to, in fact, change the ECF, and it worked. And the ethical committee is really, really, really happy that we could do it. So we are just waiting to open it. We have problems with the IDEMI platform, you know, the thing that we use to access, because that platform changed this year, and a lot of Latino researchers have problems with this because now we don't. We used to have a lot of different ways to identify ourselves, but now we don't have that. So we need to identify every researcher case by case, and it's really, really messy and clumsy. It's not easy at all. And it saddens to me to say that our main barrier right now is the access to IDEMI platform. And the GI, 019, we are translating that protocol. I'm very happy because we asked for participation and they agreed. And thanks to Deisha and Erica from the Energia and a lot of different people, like, yeah, you know, a lot of people. So we are, first time we are looking for a protocol, please invite us to that. And yeah, they agree. So numbers are moving forward. And I think we are enrolling every patient in different sites. We want to open more sites. And I think that's it. Oh, sorry.
Thank you so much, Javier. Now, for some technical difficulties, it seems that our colleagues from Colombia that were scheduled to present could not join us in the call. So we are gonna skip their presentation and we're just gonna move to the final presentation of the day by Dr. Paula Cabrera, who joins us from Mexico to briefly, Paula, 3-4 minutes to talk to us about the efforts at INCAN. We heard a little bit from Dr. Cabrera before about the efforts in the Hispanic population as they relate to the tobacco related cancers. So please just let me know when you want me to move the slides.
Yes, please. Thank you very much for the invitation. Unfortunately, I couldn't be there, but maybe next meeting. Next slide, please. As you know, Mexico has 126 million people, and cancer is the first cause of death in Mexico. Next slide, please. As we have a new general director, Dr. Arrieta has already defined that palliative care, psychology department, nutrition department, and hereditary cancer clinic belongs to the division of medical oncology and hematology. This is going to be a huge opportunity for medical oncologists to get involved in very, very, very interesting SWOG trials in the next future coming. Next slide, please. And as well, when you know, Dr. Retama said, it has been very challenged to include patients for the prostate cancer 1802, with the lung cancer 1827. Maybe Dr. Luis Cabrera, who is over there, could explain some of the barriers that we have already in this lung cancer trial. But, well, we have already 4 patient recruitment since that. And we are very happy because we are just have the approval from the Ethics and Investigation Committee to begin with young women breast cancer S2013. And in the meantime, with immuno checkpoint inhibitor toxicity 2010, we are very glad to have this approval. So maybe you are going to have a good recruitment in the next months. Next slide, please. And well, we are trying to move our efforts to continue to the breast cancer catheter trial. Also, we are trying to include the medical oncologists that do head and neck carcinomas, and they are very enthusiastic to participate in HN009. That has been finished translating and starting the ER-based submissions. So we hope to have good news soon. And finally, we are trying to get in the 1703. And as you see, all these trials are just to try to ask questions that in clinical practice are very important. That's what our group are very excited. Next slide, please. Finally, I want to communicate to all of the audience that we have an increase of 20% of the staffs at INCAN, the physicians who work or are involved with SWOG trials. So we are very enthusiastic with this young oncologist that has been involved in the SWOG initiative at Mexico. Next slide, please. Next slide, please. We have a challenge in the participation subcommittee. And well, Dr. Anna Shine was talking about barriers. I'm glad to communicate that our new general director, Dr. Arrieta, has a talk and well, a negotiation with our approval authority, who is COFEPRIS, and COFEPRIS is hopefully to help us to the SWOG trials, give the approval as soon as possible. And also, Dr. Arrieta has made a change at the inside of INCAN, trying to reduce the time on approvals of the Ethicals Committee. And the next slide. That's all, I think. Thank you very much. See you later.
Thank you, Paula.
Thank you for the invitation.
And we have 1 minute.
Yes, of
So I
course.
just want to use this 1 minute to thank you all for being here. As you all know, we keep trying to learn more and more about the barriers for each one of the sides. So to each one of the PIs, the collaborators that have joined us online, thank you. We work very closely with our SWOG operations team, and we want to thank them. The Hope Foundation really has been key to keep this program alive, and we want to recognize them for that. We
Yes,
do
of course.
have our group of we call it Slayers, 2 of them key members sitting here, Dr. John Crowley and Kurt Malloy, and of course Deja here. So Kat, it's not here, but it's part of also the ops team. So we really just want to, you know, recognize the efforts on our you know, colleagues and you all, and Connie's here from the ops side. We so appreciate what you guys do for us. So thank you. Please enjoy the meeting. Go to all the committee meetings. This is about you interacting with investigators at SWOG. So you are a SWOG investigator. So that's what we want. Have a great meeting, and thank you for joining us.
Thank you.